everyone, this is Dr. Priyadarshini, one of the mentors at StudyEFOG, and today we are going to talk about obstetric emergencies. Obstetric emergencies are life threatening medical problems, and these are considered important in management of patients. In any kind of emergencies, we need to apply the basic principles of airway, breathing, and circulation. But what makes obstetric emergencies important is to remember that the fetus is always there, and this fetus is vulnerable to maternal hypoxia. Hence, a timely management is important for any kind of obstetric emergencies. Going to a scenario, we have a 40-year-old woman who has had a previous cesarean section and she is having heavy vaginal bleeding following her vaginal delivery. She is delivered at 36 weeks. The birth weight of the baby is 3.8 kilograms. 10 minutes before the delivery, there was an acute onset of fetal bradycardia and cessation of uterus contractions. The urinary catheter shows hematuria. The placenta was delivered without any complications. While trying to do a bimanual compression, it was extremely painful to the woman. So, despite a blood loss of just 500 ml, she is appearing very pale, clammy, with a BP of 90 by 30 and a pulse of 120. So, what is the reason or what is the most likely cause for this excessive genital tract bleeding? The options we have are excessive epidural analgesia, retained placenta, uterine atony, inversion, or rupture. Now, going back to analyze the situation, this woman has had a previous cesarean and now she has delivered vaginally. So, it's a case of vaginal birth after cesarean section. We see the birth weight of the baby is 3.8 kgs, so which is a little bit on the higher side. And also, just before delivery, there is fetal bradycardia, there is absence of the uterine contractions, and hematuria. Compression is extremely painful, so that means there is something inside which is causing pain to the women. And also, she's got hypotension and tachycardia with active genital tract bleeding. So, putting in all these factors together, the most possible explanation for this condition is going to be a case of uterine rupture. So, now understanding uterine rupture, this most common symptoms and signs are to have a fetal heart rate abnormality, abdominal pain, sudden heavy vaginal bleeding. The uterine contractions will there can be a sudden cessation of them. The women can have hypotension or cardiac arrest and hematuria. So, these are some common signs and symptoms of uterine rupture. Now let's go and understand these conditions. The most common ones that we encounter are maternal collapse, major hemorrhage, which can be either antepartum or postpartum, eclampsia, rupture uterus, inversion of the uterus, shoulder dystocia, cord prolapse, and maternal sepsis. So, quickly to revise about mitral collapse, this is an acute event where there is going to be a cardiorespiratory system involvement or the central nervous system involvement. What will this lead to? There's a reduction in the conscious level. This can happen in any state of the pregnancy and up to 6 weeks after birth. So, what are the causes of these? We have some correct or reversible causes, which we have four T's, 4H and E. E stands for eclampsia, the 4T being thromboembolism, anesthesia toxicity, cardiac tamponade, and tension pneumothorax. The other causes are hypoxia, hypovolemia, which can be seen in any kind of hemorrhage, metabolic causes like hypo or hyperkalemia, and hypothermia. So we have an algorithm which we can follow. The first thing is to place the women in a safe environment and to stimulate an access for response. If she is responding, of course, we're going to bring in more medical help and help her in management. But what to do if she is not responding? Then immediately we need to shout and call for our resuscitation team. We are going to follow the principles of ABC, which is airway, breathing, and circulation. We have to make sure the airway is open and look for breathing for up to 10 seconds. If the woman is breathing normally, then we are going to help her recover, put her in a good position. And always the method of assessing the woman or to see how she is progressing, we use the chart which is a Muse chart. And then if we see that the woman is not breathing, then that is the time to start CPR. For CPR, we are going to do 30 chest compressions at the rate of 100 per minute. We are going to depress the chest by almost 5 to 6 centimeters at the center level, followed by two ventilations. So it is 30 compressions and two ventilations. This will be followed till we are going to use the defibrillator mode. Now, when we are going to attach the defibrillator, we have to assess for the rhythm, whether there is asystole or there is fibrillations. If there is fibrillations, then it is going to be one shock. If there is asystole, then what do? We are going to follow again CPR for by the ratio 30 is to 2 for another 2 more minutes and again reassess her. So this is how we are going to do the management of maternal collapse. However, remember, following the steps, following the algorithm is very important. This cannot be done as an individual. So teamwork, calling for help and having your team by your side is very, very important. Also, not to forget, documentation of such cases and incidences is also of value. Next, going on to conditions like obstetric hemorrhage. Obstetric hemorrhage can be minor, major, it can be in any duration like antepartum, intrapartum, or postpartum. The most important ones to remember in antepartum hemorrhage are placenta previa, abruptions, and ruptured uterus. Postpartum uterine atony, very, very common cause of postpartum hemorrhage, followed by retained placenta or tissues, laceration of the perineum or the vagina, and placenta accreta. Early pregnancy hemorrhages, which can be of great importance or very severe, are ectopic pregnancies, molar pregnancies, any abortions, or retained products. Now, coming to postpartum hemorrhage, again, we can classify this postpartum hemorrhage as primary and secondary. Primary is within the first 24 hours of childbirth, and secondary is within 24 hours to 6 weeks. Depending on the amount of blood, this can be again classified into minor and major. Minor, we have the blood loss of 500 to 1000 ml, and major is any time which is more than 1 liter. Again, major can be further divided into moderate and severe, where moderate, the blood loss is between 1 to 2 liters, and severe, the blood loss is more than 2 liters. It is also necessary to understand the blood loss quantification, because depending on the maternal response to the amount of blood loss, the resuscitation step also varies. So, whenever the woman loses, say, about 15% of blood, that is on an average 900 ml, there is the woman is completely asymptomatic. But when the blood loss increases to 1.2 to 1.5 liters, then there are symptoms like mild tachycardia, tachypnea, and orthostatic hypotension. When the blood loss further increases to 1.8 to 2.1 liter, then the woman has severe tachycardia. We see the heart rate going more than 120, severe tachypnea more than 30 breaths per minute, and this is when there is severe hypotension, the extremities become cold. When the blood loss goes more than 2.4 liters, that is when the woman loses 40% of the total blood, then there is oliguria and decreased conscious level. So this gives us a rough estimation of what is the amount of blood she has lost and what are we going to, or how are we going to treat her. So, coming to major obstetric hemorrhage, which is always considered an emergency in the antepartum period. Now, as I mentioned, this can be because of an abruption of the placenta or placenta previa. These are the two very, very common causes of major hemorrhages. Now, we'll have to first assess what is the amount of blood loss, whether she's in a stage of shock or no. Always, for any kind of emergencies, we need to have our team. So we need an whoever is the midwife available. Along with that, we need one more experienced person. We need to call on at alert the consultant of obstetrics and anesthesia, and also clinical hematologist needs to be informed, arrange for blood and keep. Okay. Next, we're going to apply the principles of airway, breathing, and circulation. It is very vital to maintain circulation because we know she's actively losing blood. So, ideally, two 14 gauge intravenous needles is required for her. The basic idea in or the basic pillars of these kind of emergencies are to have an appropriate management with the team, with the women and her family members, to have a multidisciplinary approach, and to have proper resuscitative measures in place. We'll need to look at the investigations that are already available and the investigations that we are right now carrying out for the women. Arrest bleeding. We know she's losing blood, so the main idea is to arrest bleeding. And so the basic idea, whenever there is no shock, we have to give, like whenever the blood loss is up to 1 liters, then we need to have an immediate access to the intravenous system, and we are going to start off with crystalloid infusions. Now, when the massive hemorrhage or the blood loss is more than 1 liter, or there is clinical shock, then we are going to apply the principles of ABC, that is airway, breathing, circulation. We need to give her oxygen at by 10 to 15 liters per minute by mask, and we need to have the IV access and start the fluids. The position of the women, the most preferable one is going to be the left lateral tilt. We are going to keep her warm. We know that hemorrhage is going to make her cold, so we have to make sure the extremities are kept warm, and the immediate measure is going to give blood. But what to do till we do not have blood or there is some delayed? Then we are going to give her some fluids. So the fluid that is of choice to start is our crystalloid Hartmann solution, 2 liters, preferably a warm one, followed by colloids if crystalloids are not available. So crystalloid is the first one of choice. So second thing, if the blood arrives, give it immediately. Always we need to check cross match and give the blood. So what is the basic fluid therapy behind this management? So crystalloids is up to 2 liters of Hartmann's. Colloid is 1 to 2 liters until the blood arrives. Blood, always cross-matched blood. If it is not available, we go in for ORH negative blood. FFPs, the idea of using FFP of fresh frozen plasma is we give 4 units of FFP for every 6 units of red cell that is transfused. The other way to assess it is by using parameters like prothrombin time and activated partial thromboplastin time. So whenever the APTT goes more than 1.5, then it is time to use FFPs. Using other components like platelets, whenever the platelet count goes less than 50, and cryoprecipitate when we find the fibrinogen level is less than 1. So, having a rough idea about postpartum hemorrhage. Now, postpartum hemorrhage, as I mentioned, can be divided into primary and secondary. Primary is seen in the first 24 hours. The most common cause of this being having a very poor uterine tone, which can be assessed by doing an abdominal palpation. Next can be some traumatic causes like tears. It can be either in the cervix or the vagina, which leads to massive hemorrhage. Retained products is another important cause. A bit of placenta or membrane which is stuck inside the uterus can cause massive hemorrhage, and coagulopathy can set in. Secondary postpartum hemorrhage, most common causes are endometritis, that is some infection within the uterus which causes bleeding, pseudoaneurysm of the uterine artery or any uterine vessel abnormality, and retained tissue which is left unattended for a long time can present as secondary postpartum hemorrhage. Now, what are the important things to remember in the management of major postpartum hemorrhage? Now, major postpartum hemorrhage is blood loss more than 1 liter. So, what we have to do first is to arrest the bleeding. Call for help, alert your team, make sure your anesthetist and the obstetrician, the senior ones, are involved. The hematologist is there, and we are going to start and apply the principles of ABC: airway, breathing, and circulation, give oxygen, maintain fluids, and arrange for blood. Now, going on to arrest the bleeding, we have to first go and see what is the cause of bleeding. Now, as I mentioned, the most common cause of PPH is going to be atonic uterus or atonic PPH. So first we'll see what are the investigations that is important. We're going to put on her two 14 gauge needles, ask for full blood count and coagulation profiles, urea electrolytes and LFTs. For cross matching, we need 4 units, FFPs, platelets and cryoprecipitate. These are the most common blood components that we use. We need to connect her to an ECG, pulse oximeter, Foley's catheter, and do a hemoglobin bedside testing. Make sure that the blood products arrive in time. If the blood products are not arriving, then we'll have to make sure that we are giving some kind of fluids to maintain the hemodynamic stability. Now, for atonic uterus, we need to first follow the medical management. If failed, we go on with the surgical management. Now, medical management, what are the drugs we are going to use? First thing, we need to rub up the uterine fundus to make sure to bring in some contractions. We have to see that the bladder is kept empty so that there is no physical obstruction or mechanical obstruction for uterine contraction. We need to start off with oxytocin, which is a basic uterotonic drug. We are going to give 5 international units as slow IV. We can repeat it if necessary. The second drug of choice is going to be ergometrin, but make sure the woman has not got any hypertensive disorders or cardiac disorders or drug allergies. So we give it as slow IV or IM, it is zero point 0.5 milligram. We can also think about using oxytocin infusions of almost 40 international units, put in a drip of 500 ml and give it as slow infusion. The other drug, the next drug is going to be carboprost. We can give it as 0.25 milligram IM every 15 minutes, maximum up to 8 doses. The other drug is using intramyometrial carboprost 0.5 milligram. Misoprostol or PGE1 can be given 800 micrograms sublingually. Tranexamic acid is a drug that has to be used in major PPH for control. Now, coming to surgical management of PPH, we need to shift the patient to the operation theatre, and there again we need to assess whether the uterus is well contracted or no, to look under anesthesia to see if we have missed any vaginal or cervical tear which is bleeding, and also to see if there is any clotting abnormality that has been corrected. Now, coming to the use of mechanical methods like balloon tamponade, the most common balloons we use are Bakri balloon or Sengstatin Blackmore balloon. The idea is you put it intrauterine, fill it with some fluid so that there is some mechanical compression and arrest of bleeding. Coming to the various surgical interventions for PPH, the most common one is use of brace sutures, which is the B-Lynch sutures. The other sutures or hemostatic sutures are core sutures that can be used, or Heyman sutures. Followed by which, if still the woman is bleeding and there is major PPH not being controlled, we go in for something called a stepwise uterine devascularization, where we start, ligating the vessels first unilaterally and then bilaterally to cut off the blood supply to the uterus. The last mode is again going to be ligation of the internal iliac artery. If all these modalities fail, the woman is still bleeding and we do not have a management option left behind, then we go in for hysterectomy, where we always have an experienced obstetrician by the side to do this. If available options of intervention radiology are present, then we can think of uterine artery embolization. And always remember, following a PPH, especially a major PPH, the woman has to be kept in the high dependency unit or the intensive care unit for further observation. So, applying these steps, applying these algorithms will definitely help us to understand the clinical scenario that's given in exam and solve the questions better. Going into one more obstetric emergency is uterine inversion. Uterine inversion is commonly seen after the delivery whenever there is inadvertent pulling of the umbilical cord and causing an idiopathic or an iatrogenic cause of uterine inversion. Now, uterine inversion, again, the women can present with shock or hemorrhage. The main features is going to be an out of proportion shock, and we see the blood loss can be minimal, but the shock or the clinical features in the women can be major. Now, the types of inversion can either be first degree, where there's just a small dippling, second degree, third degree, where we see the uterus partially outside the introitus, and fourth degree, the uterus is completely outside. Now, what we do, we see the women is in shock. So, again, we have to apply the principles of ABC, that is airway, breathing, and circulation. We're going to put in two wide bore cannula, arrange for blood, and start off with fluid management. Now, coming to the management per se of the uterus, we need to try to attempt and replace the uterus as soon as possible. We are going to start off with manual replacement. If we find the uterine tone is increased, the uterus is well contracted, then we have to give some relaxants like terbutaline to relax the uterus, which can help us put back the uterus in place. Now, if the manual replacement of the uterus fails, then we need to go in for other methods. We start off with O'Sullivan's method, which is the hydrostatic replacement of inversion of uterus. If this is successful, then we give her some uterotonics to make sure the uterus is well contracted. Now, if this fails, then we need to take the women for laparotomy and do some surgical techniques to pull the uterus back in position. Now, as I mentioned, these are the various management techniques we have for uterine inversion. The first picture that we see here is the manual replacement of the uterus. If this fails, we go in for the hydrostatic method where we're going to use some fluids to push back the uterus and keep it in place. If failed, then we go for laparotomy. The two most commonly done techniques are the Huntington's procedure and the Holstein procedure to put back the uterus in place. Now, coming to one more dreaded complication is rupture uterus. Now, rupture uterus is very, very commonly seen after vaginal birth after cesarean, but not to forget, it can occur even without a previous cesarean. So, any scarred uterus, the woman is in labor, we need to think about ruptured uterus, though it can happen occasionally or rarely in unscarred uterus too. Now, we have two different entities to remember. One is an impending rupture and one is a complete rupture. Now, what do you mean by an impending rupture? Looking at the symptoms and signs, the labor is not progressing. The woman can be agitated. There can be an altered mood. The uterus is hypertonic, so we need to look at the CTG to see how frequently the contractions are. There can be bandle string. That means the woman is in obstructed labor, which is going to put her or make her a high risk for rupture of uterus. The abdominal pain can be very severe. It can be more than the labor pain. Now, in rupture, what happens? The contraction is going to completely stop. And because there is rupture, the woman goes into the state of shock. Sometimes even there can be intrauterine death, and we can see or freely palpate the fetal parts in the maternal abdomen. Now, what do we do for management? Anytime rupture is confirmed, we need to take her for an emergency surgery and try to deliver the baby out and save the mother from the state of shock. Now, if there is impending rupture, then we have to make sure we deliver the baby safely as soon as possible. When we see that the woman is just about to deliver, like when the delivery is imminent, then you try and expedite the delivery either using vacuum extractor. If not, vacuum extraction is not possible, then we have to think of other methods, like is it possible to deliver her quickly with a forceps, or do we have to do a cesarean section? Now, whenever we find that there is signs of an impending rupture and labor is not going to be very soon, then we need to do an emergency surgery and remove the baby out. Now, coming to other complications which can present as emergencies, the most common one that we encounter is eclampsia. Now, in eclampsia, always try to remember the algorithm for management of eclampsia. We need to call for help. This cannot be dealt as an individual. You need to inform your anesthetist also. Once your support is ready, make sure airway breathing circulation is always maintained. Do not compromise on time for managing airway breathing and circulation. Controlling seizures is important. The drug of choice we use here is magnesium sulfate. We give a loading dose of 4 gram IV slowly over 5 minutes, followed by the maintenance dose. The maintenance dose is given at the rate of 1 gram per hour IV for at least 24 hours following the last fit. In cases of recurrent seizures, we are going to give magnesium sulfate 2 gram bolus over 5 minutes. Now, once the eclampsia settles down, then we have to also remember to control our hypertension. The drug of choice is going to be IV labetalol. So, managing cases of eclampsia, as I said, always resuscitation is the first method. Do not waste time. We need to start airway breathing circulation immediately, and the drug of choice is going to be magnesium sulfate for management of the fit. For hypertension, whenever we see that the BP is more than 110 to 160, always the drug of choice, the first drug of choice is going to be labetalol. Now, in cases of crisis or when we find that hydrolysin is available, that is again a vital drug in saving us when the BP is very high. The role of hydrolysin or the dose is going to be 5 to 10 milligram IV over 3 to 10 minutes. However, remember, before giving hydrolysin, we need to put it on some infusion so that there is no severe hypotension following use of hydrolysin. The other drug that can be used in cases of severe hypertension is nifedipine. Nifedipine is going to give us we have immediate release tablets, so that is going to be an immediate rapid fall of BP. Next, birth plan must always be kept in place because the ultimate treatment of eclampsia is going to be delivery of the baby. It's the delivery of the baby that is going to bring the BP down. But even after delivery, the women must be kept under close observation because eclampsia can also be present in the postpartum period. So, whenever given a clinical scenario, always remember eclampsia has to be ruled out before thinking of other causes of seizures in the postpartum period. Coming to another dreaded obstetric complication is shoulder dystocia. Shoulder dystocia, this is a very, very famous algorithm for management of shoulder dystocia. What do you do, or whenever the emergency buzzer goes in the labor ward and you're called for help? First thing, discourage the women from pushing. Bring her to a proper position. Bring her to the edge of the table and then call for help. Your team must always be ready to help you. The first maneuver that we apply here is the macrobots maneuver, where we are going to hyperflex the women's thighs. Next is the consequent application of suprapubic pressure. The use of macrobots and suprapubic itself is going to be successful in majority of the cases. Now, if this is not going to work and the baby is still stuck, then we are going to consider episiotomy if needed for us to perform any internal maneuvers. Now, internal maneuvers, the various ones available are delivering of the posterior arm or doing other maneuvers. Now, if whether we are going to use the internal maneuvers or whether we are going to deliver the posterior arm depends on the expertise. Always remember the consultant must be involved, both the obstetrician and the anesthetist who are going to help us with such emergencies. Now, if all the maneuvers of shoulder dystocia fail, then what are we going to do? We are going to consider the all fours position, or we can repeat all the above maneuvers. If everything fails, then the last one is going to be cledotomy or Zavanelli maneuvers is going to be applied. In all these cases of obstetric emergencies, documentation is very, very important. Not to forget, there can be questions which is going to ask us about documentation and debriefing. So keep that also in mind whenever there is a question on emergencies to look at all the aspects. And a simple tip to remember is to follow the algorithm so that we understand from the clinical scenario what step has been done and what next to be do and which is the crucial drugs that we have to use in all the emergencies. Cord prolapse. Cord prolapse, the most common reasons can be following rupture of membranes, which can either be an artificial rupture of membranes or spontaneous rupture of membranes. So, whenever we do a vaginal examination, it is necessary after every vaginal examination to ensure that the baby's heartbeats are fine, more so after rupture of membranes to rule out cord prolapse. Now, suppose if the woman has got some risk factors like polyhydramnios or a breech presentation, then the incidence of cord prolapse further increases. We need to act quickly. The cord kept outside the vagina or if handled frequently is going to cause severe hypoxia to the fetus. So organize your help quickly. Arrange the midwife, the obstetrician, and the anesthetist put as a team. Arrange quickly for delivery of the baby. The neonatal team is very important because they are the ones who are going to take care of the baby, and the baby can be compromised in most of the cases of cord prolapse. So, what are we going to do to relieve the pressure? We have to act immediately to make sure that we elevate the presenting part or fill the bladder so that the cord can be pushed up. Put the women into left lateral position with the head down or knee chest position. Consider tocolysis if there is severe contraction of the uterus. Decision of birth, we have to deliver her immediately from the If it is taking place in the labor room, shift her immediately for to the theater for cesarean section if there is no imminent delivery. If it is happening in the community, then she has to be shifted to the hospital in an emergency basis. Now we have to see that delivery is not always by cesarean section. If you think the woman is complete fully dilated and delivery is going to be imminent, then you can go in for a normal delivery. But however, if the delivery is remote, then we have to think of emergency cesarean section or category 1 cesarean section. Coming to sepsis, sepsis is a very, very important cause of maternal death. So, understanding sepsis to know what are the symptoms and signs and to give an appropriate treatment is considered as always an obstetric emergency, because we have the golden hour of acting in sepsis. Now, sepsis starts with SIRS, which is a systemic inflammatory response syndrome. If along with that there is some confirmed or suspected infection, we label the woman as sepsis. Now, along with this, if the woman has any signs of end organ damage or severe hypotension or the lactate level goes more than 4, then we consider that as severe sepsis. The last stage and the most severe stage is septic shock, where the woman has signs of end organ damage with persistent. These signs are persistent, whereas in severe sepsis, they can be reversed also. So, in pregnancy, already there are a lot of maternal complications and maternal compromises that take place because of pregnancy. Now, add on to that, if there is sepsis, the women can easily deteriorate. What happens? There can be a rapid hemodynamic collapse, which involves the cardiorespiratory system. There can be possibility of pulmonary edema, so oxygenation decreases a lot, and the women can land up in adult respiratory distress syndrome. There can be acute kidney injury and leading to oliguria, and there can be microvascular thrombus formation because of sepsis. Now, coming to management of sepsis, the most important thing to remember is the sepsis 6 bundle. We need to give 3 in and 3 out. Now, what are the things to give to the mother? Give her oxygen to make sure the saturation is more than 94%. Give her IV antibiotics and give her fluids. What else you have to do to her? We have to take 3 things outside. What are they? To take blood culture before you give the antibiotics, measure the lactate levels to understand the severity of the sepsis, and measure the urine output, because kidney injury is very, very common, so that we have a control over what is happening inside her. Now, what do we do in management of sepsis? Time is very, very important. We need to act within 1 hour of any suspicion of sepsis. Any further delay in management is going to cause severe maternal and fetal deterioration. Obtain cultures, lactate, give her antibiotic, give her fluid, give her oxygen. This is the first step. Now, after giving all this, we need to assess what is her mean arterial pressure. We need to maintain it above 65. Now, suppose if the mean arterial pressure drops down to less than 65 and there is evidence of hypoperfusion, we need to start her on norepinephrine. And we have to give her steroids if she's not getting settled with any of this, or when there is no response to norepinephrine. We have to see what is the source of sepsis, try to identify the source and treat her accordingly. Now, if the woman is pregnant, if this is happening in pregnancy, then we should also look into the fetal well-being. And if the fetus, the gestational age is less than 24, then we have to put her to see into the multidisciplinary team to see whether the pregnancy can be continued further, to see if we have to use steroids for lung maturation. So the MDT comes into action when in early pregnancy there is sepsis. Now, for the women, we need to also remember that start of DVT prophylaxis is important in sepsis, as she is at a very high risk of developing venous thromboembolism. So these are some very common conditions in obstetrics which are considered as emergencies. Now let us look into some more questions which can help us understand better what comes in the exam and how we need to be prepared for the same. We have a question here asking us what is the most common reason for litigation following a shoulder dystocia. Shoulder dystocia, we know, can be associated with a lot of complications both for the mother and the baby. However, litigation is very, very common following a brachial plexus injury. So the answer for this is going to be brachial plexus injury. We have another scenario where we have a massive postpartum hemorrhage and the woman is going to have a fibrinogen level of 1.5. So which is the most appropriate product which is going to help her elevate her fibrinogen levels? The options that we have are cryoprecipitate, fibrinogen concentrate, FFP or fresh frozen plasma, tranexamic acid and whole blood. Now, whenever there is massive hemorrhage and they're given a fibrinogen level, the answer is cryoprecipitate. This is the option we are going to choose when we have to elevate only fibrinogen replacement. So whenever we have a target level or the target level is not known, we are going to use cryoprecipitate. So the maintenance of fibrinogen is at least 2 gram per liter. Anything less than that, we have to use cryoprecipitate. Next, we have a scenario. We have an emergency buzzer that has been activated, the indication being shoulder dystocia. Now, you are instructing two junior midwives to assist you in delivery with McRoberts maneuver. So, what are you going to tell them to do? That means basically you need to understand what is a McRoberts maneuver. The options that we have are flex the maternal thigh to her abdomen, hyperflex the maternal thigh to her abdomen, do an episiotomy, place the mother in a lithotomy position, and next is provide a fundal pressure. Now let's analyze the options that we have here. We are only starting the management of shoulder dystocia. So we are going to tell the junior midwives about McRoberts maneuver. One thing, there is no fundal pressure. There is no role of fundal pressure in shoulder dystocia. So option E is ruled out. Placing the mother in lithotomy position. Lithotomy, yes, it is a good position, but however, in shoulder dystocia, we need to change it a little. Doing an episiotomy is only for assessing whether we need to do some internal maneuvers. So it's always a plus or minus. However, to start off with, we need to understand what we are doing in a McRoberts maneuver. So we are left with option A and option B. So whether we are going to flex the maternal thigh or whether we are going to hyperflex the maternal thigh. The answer is hyperflexing it to her abdomen. Now, what happens or what changes does this McRoberts maneuver bring into? So that we have a clear understanding of what's happening with the women. So before doing a McRoberts positioning, we see there is a diagonal orientation of the pubic symphysis, so the shoulder delivery becomes difficult. Whereas after performing a McRoberts position, there's a change in the pelvic tilt or orientation. The symphysis pubis becomes more horizontal and the sacrum becomes flat. So, for performing a McRoberts maneuver, we need to instruct our midwives or our coordinator to hyperflex the patient's thigh or the maternal thigh towards the abdomen, which will help us create this McRoberts position. Now we have another scenario here. We have a woman who is a recent immigrant and she's admitted in labor and she's going to deliver or she has delivered rapidly. At delivery, the midwife has seen that the liquor was very offensive and swabs have been taken for that. The mother is also noted to have a low grade pyrexia and she has mild tachycardia too. So there are signs of some infection. So what happens? The antibiotics being administered. So within minutes after giving the antibiotics, the mother collapses and there is a diagnosis of anaphylactic shock. So the protocol of A, B, C, D, E has been initiated. So what is going to be the definitive management of anaphylaxis? So what is the drug we are going to use? Adrenaline. Is it going to be 50 micrograms intracardiac? 1 in 10,000, or is it going to be zero point 0.5 ml, that is 500 micrograms IM, or is it going to be 500 micrograms IV, or we are going to use any other drugs like chlorpheniramine. Understanding anaphylaxis is important, especially the drugs. So E stands for airway, breathing, circulation, disability, and exposure. Now, coming to the drug of choice, it is 500 micrograms or zero point 0.5 ml of adrenaline, which is given intramuscularly. We are dealing with an adult patient, so the drug is 500 micrograms. For child more than 12 years, again, it's going to be 500 micrograms. However, for pediatrics, the drug level reduces. So the drug is 500 microgram or zero point 0.5 ml. The concentration we are giving is 1 in 1000 and the route of administration is intramuscular. Understanding some AMQs or extended match questions, we have some option that is given to us and we have a scenario. The question asks us, for each description below, choose the single most appropriate answer from the list of options. Now, these options can be used once, more than once, or not used at all. Looking at the scenario we have a 39-year-old woman. This is her first pregnancy. She is being induced for symphysis pubis dysfunction at 38 weeks. Now, in first stage of labor, she is noted to have uterine hyperstimulation. So they have stopped it. They have stopped the oxytocin infusion and reduced it. After that, she was delivered later by a lower segment cesarean section and the indication being a suboptimal CTG. 2 hours after delivery, she has complained of shortness of breath. On examination, she is noted to be cyanotic, pulse is 100. Chest X-ray shows that there is bilateral ground glass appearance with an impaired coagulation profile, right? So let's go back into the scenario. We have a woman who was just delivered by cesarean section, and the main features are shortness of breath, cyanosis, and bilateral ground glass appearance. So looking at the option we have, it can be whether it can be pulmonary embolism, amniotic fluid embolism. So we know that we are dealing with the respiratory system. Can it be eclampsia? Less likely. Why? Because the central nervous system, there are no signs. Can it be abruption? There is no mention of a massive blood loss. Can it be epilepsy? Again, there is no mention of fits. Postpartum hemorrhage? No, less likely. In disseminated intravascular coagulation, yes, there is a mention that the coagulation profiles are altered, but other signs do not fit into it. Subarachnoid hemorrhage, no. Aortic stenosis, there is no mention of cardiac history here, so less likely. Hyperventilation, no. Migraine, vasovagal attack, hypoglycemias, aortic dissection, cerebral hemorrhage. So with the options that are available here, so that is something that is likely correlating with the conditions can be pulmonary embolism and amniotic fluid embolism. Now, what is the major differences or how can we differentiate between both? Now, for pulmonary embolism, we need to think of factors that can be a high risk factor for developing or putting her into pulmonary embolism. Now, pulmonary embolism, we see most common is going to following a DVT. So, there is no risk factors for DVT that has been mentioned here. So or other factors like obesity or prolonged labor, nothing has been mentioned here, or sepsis is also not here, which puts her into the complication of VT. So analyzing the situation and looking at the option, the most likely option in this condition is going to be amniotic fluid embolism. So, what is amniotic fluid embolism? It is a condition in which the amniotic fluid escapes into the systemic circulation. It goes into the lung and brings in some inflammatory changes in the lungs. So, these inflammatory changes will appear as ground glass appearance in the chest X-ray. Understanding this is important because we can have scenarios which we need to decode and come to an answer. Now, we have one more scenario that is there for us. We have a 22-year-old woman in her first pregnancy. She is presenting to the accident and emergency at 14 weeks of gestation, and she's got sudden severe occipital headache. And she also has projectile vomiting before she has arrived. And after admission, her GCS goes down to 3. So we have a young woman. She's come to accident and emergency. So that means that there is a real emergency. Main complaint is headache. Region is occipital and it is sudden. And she has projectile vomiting. So the associated symptom is projectile vomiting. And if you look, the GCS is very low. It falls it rapidly to 3. So going back to the options we are dealing with a central nervous system problem. So what are the options we have that is corresponding? It can be a subarachnoid hemorrhage or it can be a cerebral hemorrhage, which are the most likely fitting options here. If they have given only headache, then probably we can think of migraine. And if they have given an option, if the woman is a known case of epileptic or now she's throwing a seizure, then we need to think of epilepsy too. Now, giving the options of subarachnoid hemorrhage and cerebral hemorrhage, sudden severe onset, rapid fall of JCS and occipital region, most likely it is a case of subarachnoid hemorrhage. So for EMQs, we need to split, we need to think what is the lead statement we have, what is exactly asked, whether it is the treatment, whether it is the management, whether it is the first line management, second line management, all that has to be looked into. And then we need to analyze the situation. We need to look at the risk factors, we need to see what we are dealing with, and then we need to come to the appropriate answer. So, this is a wrap up of the some important and common obstetric emergencies we face. Hope this video was useful. You can see it on YouTube. Most importantly, remember to subscribe to our YouTube channel. We have n number of videos which is going to help you prepare for the exam for all various streams. And for EBCOG, we have started it. So, stay tuned. Go to the link, make sure you watch the YouTube videos again and again repeatedly. I'm telling you, this is going to be very important right before your exam preparation. Stay relaxed, look at the videos, and happy learning. Thank you.